So now let's talk about dietary requirements. Dietary reference intakes are estimates of the amount of nutrients required to prevent deficiencies and maintain optimal health and growth. So meron tayong apat na dietary reference intakes. The first one is our estimated average physiologic requirement or EAR. So this is actually the amount of nutrient essential to meet the nutrient requirement of half of the healthy individuals in a sex and life stage group. But what does that mean? An example of a sex and life stage group is males aged 19 to 29 years old and infants aged 0 to 5 months. So, merong mga specific amounts of nutrients that these specific sex and life stage groups have to consume in order to prevent deficiencies, in order to promote proper nutrition. So, yung ating EAR, ini-estimate niya yung amount of nutrient na kapag kinonsume, there is about 50% chance of deficiency. This is in contrast with our recommended dietary allowance. So our recommended dietary allowance or RDA is the average dietary intake necessary to meet the requirement of nearly all healthy individuals, so about 97 to 98% in a particular gender and life stage group. Our RDA is equal to our EAR, our estimated average physiologic requirement plus 2 standard deviations para makover yung mas maraming individuals sa kanyang particular gender and life stage group. Next, we have adequate intake. Adequate intake is just based on experimentally observed average intake of healthy individuals. We refer to our adequate intake kapag wala tayong values ng EAR or RDA. Basically, it's just an experimental observation na since this group of people that belong to the same sex and life stage group consume about this amount of nutrient and they are healthy. So that might mean that yung amount lang na kinokonsume nila is already enough to maintain health. The last DRI is our tolerable upper intake level. This is the highest average daily nutrient intake level that will pose no risk of adverse health effects to most individuals in the population. You can think of it as the upper limit. So, beyond which, mataas na yung ating risks of having adverse health effects. It is not meant to be used as a recommended level, but it is important to know, especially during this time when people are taking supplements or vitamins and na madalas fortify yung ating mga food items. Now, let's look at these dietary reference intakes in a graph. So, yan. Ito yung ating graph. So, this figure shows that the estimated average requirement, our EAR, is the intake at which the risk of inadequacy is about 0.5 or 50%. The RDA is the intake at which the risk of inadequacy is about 2 to 3%. Tapos, yung nasa gitna ng RDA and our upper tolerable intake level, yun yung amount at which both the risks for deficiency and toxicity are very close to zero. Beyond our tolerable upper intake level, tumataas na yung risks for our adverse health effects. Okay, so now let's look at this two graphs. So, sabi natin kanina yung ating recommended dietary allowance or RDA is equal to EAR plus 2 standard deviations. So, our nutrients have these 2 standard deviations. But when it comes to energy, wala tayong binibigay ng standard deviations kasi eksakto yung ating energy na kailangan para maintain yung ating weight. Para magkaroon tayo ng energy balance. Kapag kumulang doon, magpakaroon ng weight loss and other related health conditions. Kapag sumobra, may lead to weight gain, obesity, and the other health conditions na related sa kanila. Okay, so now let's talk about our acceptable macronutrient distribution range, or AMDR. Our AMDR is the range of particular macronutrients associated with reduced risk of chronic diseases while providing adequate amounts of essential nutrients. So, for our carbohydrates, that's 60 to 65%, protein 15 to 20%, fat ay 20 to 25%. That means that kunwari, the patient should ingest 1,400 calories to maintain his or her weight. So 60 to 65 of those 60 to 65% of that caloric intake should come from carbohydrates. 15 to 20% of that caloric intake should come from protein, while 20 to 25% of that caloric intake should come from fat. Let's try to apply this. For example, 1,100 calories for 1 pound weight loss weekly for the 60 kilogram carpenter that we calculated before. So if you multiply this by 0.65 for carbohydrates, 0.15 for protein, and 0.20 for fat, we'll get 1,235 calories from carbohydrates, 285 calories from protein, and 380 calories from fat. So, yung range natin ay yung 60 to 65, 15 to 20, and 20 to 25. But our standard percentages for normal, healthy population is 65, 15, and 20. If you want to know how much grams this actually looks like, divide mo lang yung calories na nakuha mo by the metabolic fuel value of each macronutrient. Later, i-discuss pa natin kung paano ba talaga yung process ng diet calculation. So, parang sneak peek lang tong mga parts na to. Okay, so now let's take a look at our macronutrients. First is our carbohydrate. So, we do not actually specify a specific carbohydrate na kailangan ingest. Depends on the nutritional goal for the patient. For example, for athletes, we recommend consuming high glycemic index carbohydrates before their workout or for their pre-workout meal. Kasi yung carbohydrates, gagamitin siya ng katawan as energy source during the workout. So, it has to consume high glycemic index carbohydrates, which it can easily digest, metabolize, and convert into energy. While for our diabetic and hypertensive patients, we focus on low glycemic index carbohydrates to manage their blood glucose and to promote the intake of fiber. Health problems arise from complete elimination of carbohydrates from the diet. Kasi if there's less carbohydrate in the diet, mas na-emphasize ang intake ng fat as fuel source. So that in the long run could cause obesity, atherosclerosis, etc. Okay, now let's look at protein. So sometimes you can also just calculate for the protein without using the AMDR by knowing kung ano yung recommended na grams of protein per kilogram body weight ng patient. So, for normal, healthy adults, that's 0.8 grams of protein per kilogram of body weight. So, for example, for a 60 kilogram man na normal and healthy, 60 times 0.8, that would be 48 grams of protein. So, that's what we call non-protein caloric energy requirement. After calculating for the protein, 8 times mo siya. So, 48 times 4 para makuha mo kung ilang calories na yung na-consume from protein. Tapos, yung remaining calories ay i-divide mo sa ating carbohydrates and fat into 70 and 30 percentages. 70 for carbohydrates and then 30% for fat. Next ay protein quality. So our protein quality is the capacity of food proteins to provide nitrogen and essential amino acids for human growth, and functions. So our protein quality, the protein quality of the food that we consume, tells us something about the amount of essential amino acids found in that food item and how easily digestible the protein found in it is. So let's look at it in terms of biological value. Biological value refers to the percentages of nitrogen absorbed from the dietary protein actually used by the body. So meron tayong tatlong classifications for biological value. First is the complete or high biologic value protein. So this means that the protein contains all essential amino acids in adequate amounts. So because of that, it can maintain life, support growth, and physiologic functions. Makuha natin itong mga high biologic value protein or complete proteins sa mga food items of animal origin such as eggs, beef, chicken, lahat ng meat. Next, we have partially complete proteins. They are proteins that can maintain life but cannot support growth. So, examples of these are gliadin in wheat and lignin in legumes. And the third one is incomplete proteins. Incomplete proteins cannot support life and growth. Samples of these are corn, gelatin, and most plant proteins. So basically, the concept here is that the higher the biological value of the protein source, the higher the protein quality. Pero paano para naman sa mga vegetarians na hindi naman sila nagko-consume masyado, or hindi sila nagko-consume talaga ng animal protein? So, we implement protein complementation for them. Basically, what we do here is that we partner the specific protein sources that are high in specific essential amino acids with food items that are low in specific food items. So, we partner them so that in the end, may intake mo pa rin lahat ng essential amino acids na kailangan ng ating katawan. So, as an example, corn is deficient in lysine and tryptophan, but has sufficient amounts of sulfur-containing amino acids such as methionine and cysteine. While legumes, kabaliktaran naman, mababa siya sa cysteine and methionine, pero mataas siya sa lysine and tryptophan. So, in meal planning, we partnered this protein para hindi maapektuhan yung protein balance ng mga vegetarians. So, they can still get all the essential amino acids that their body needs. So, ito yung table na papakita lang kung yung mga example ng mga limiting amino acids in certain types of food. Okay, now let's talk about protein balance. So, positive nitrogen balance kapag mas marami yung protein na na-ingest or nitrogen na na-ingest kaysa sa nitrogen na na-excrete. So, this happens for growing individuals when protein synthesis or intake is greater than protein degradation. Gaya ng pag sa children, pregnant mothers, or patients in convalescence or yung mga recovering patients. Nangyayari yung ating negative nitrogen balance kapag kabaliktaran naman, kapag masyadong mataas yung excretion ng nitrogen in comparison to the ingestion of nitrogen. So this happens when the protein intake is too limited or when it is deficient in one or more essential amino acids because our body needs all the essential amino acids to make protein. Otherwise, hindi mangyayari yung protein synthesis. This happens during surgery when the patient has fever, when he or she is immobilized or suffering from shock and burns. And so, another reason for negative nitrogen balance, pwede na hindi talaga siya dahil kulang din yung ini-intake ng nitrogen, but it's also because the body breaks down more tissue proteins and loses more nitrogen than they take in. So, basta ang importante, mas marami pa rin na na-excrete kaysa sa na-ingest. And of course, we have nitrogen equilibrium or balance when the nitrogen ingested is equal to the nitrogen excreted. So, next, let's look at fats. So, we have saturated fat, monounsaturated fat, and polyunsaturated fat. So, let's look at them in terms of their effect on LDL and HDL. Saturated fat is stable kasi saturated siya, so wala siyang kinks. It's more stable than unsaturated fats. But it is shown to increase LDL and pose cardiovascular diseases risks. So our saturated fats are mostly found in animal fats, in palm oil, and in coconut oil. On the other hand, monounsaturated fatty acids decrease LDL. Tapos, some sources say that they just maintain HDL, but some sources say that MUFA actually increases HDL. Our polyunsaturated fatty acids decrease LDL and increase HDL. So both of our MUFA and PUFA are unstable and they may give off free radicals. So kahit na maganda sila sa katawan, they should still be taken in proper amounts, or otherwise they could promote the development of various types of cancer because of their unstable nature. So pwede sila maging mutagenic sa ating katawan. Examples of our polyunsaturated fatty acids are found in peanut oil, soybean oil, corn oil, rapeseed oil, and sesame oil. While our PUFA can be found in olive oil, sunflower oil, safflower oil, canola oil, avocado, and nut butters. Okay, now let's talk about trans fats. So trans fats are actually liquid vegetable oils which are hydrogenated. What does that mean? Hydrogenation refers to when the liquid vegetable oils are heated in the presence of hydrogen gas in a catalyst. So kapag naging hydrogenated yung ating vegetable oil, magiging mas stable sila. Bakit nila ginagawa mas stable? Para hindi magiging rancid agad yung oil. So mas mahaba yung kanyang shelf life. But in the process, this makes the vegetable oil detrimental to our health. So usually, sinasabi namin sa parang no trans fats, ganyan, or it can be found in certain food items na medyo nakatago yung name niya. It's actually can be found in food items with partially hydrogenated oil and vegetable shortenings. Kasi ito ay basically yung mga trans fats lang din, pero other term siya kasi yung term na trans fats ay medyo masakit na sa tenga natin. And also, our trans fats are naturally found in beef fat and in some dairy products, but in very small amounts. So, what does our trans fats do? Our trans fats raise LDL, it lowers HDL, is pro-inflammatory, and contributes to insulin resistance, and even increases risk of coronary heart disease. So basically, this is what happens. We have yung ating unsaturated na vegetable oil, and in the process of hydrogenation, magiging mukha siyang saturated. Kaya sinasabi siyang vegetable shortening. Usually, ito yung mga nilalagay sa mga baked products such as margarine, any shortening. Kasi di ba parang medyo solid na siya. Kasi kung isipin natin, kapag hydrogenated na yung oil, kagaya ng nakita niyo sa screen, yung structure na yan, mas madali silang magpapatong-patong. So, mas magiging solid yung oil. Unlike sa kapag may kink, or if it's unsaturated, mahirap mag-form yung oil, or parang mahirap siya magpatong-patong, so hindi siya mag-solidify talaga. That's the reason why, yung olive oil, kahit na ilagay mo siya sa ref, hindi siya nag-solidify. Unlike butter, margarine, either saturated fat sila or they're trans fats. Okay, now let's talk about our essential fatty acids. So, essential fatty acids are fatty acids that cannot be synthesized by the body because of the particular arrangement of double bonds. Actually, ito yung ating alpha-linoleic, or it is an example of omega-6, and alpha-linolenic, an example of our omega-3 fatty acid. So, bakit ba siya essential? Bakit hindi siya magawa ng katawan natin? Kasi we lack the enzymes delta-12 and delta-15 desaturases. According to this picture, our double bonds for linoleic acid ay nasa 9 and 12, while for our Alpha-linolenic acid, it's in 9, 12, and 15. And medyo kinoconsider natin na essential fatty acids ang ating EPA and DHA. They are long-chain omega-3 fatty acids that serve as precursors of eicosanoids such as prostaglandins, thromboxanes, and leukotrienes. So, ano bang mangyayari kapag na-ingest na natin itong alpha-linoleic and alpha-linolenic? Bakit sila lang yung kailangan natin i-ingest talaga? Bakit hindi tayo sinasabihan pa na i-ingest yung iba pang types ng longer chain derivatives ng fatty acids? Kasi hindi naman sila yung pinaka mahaba. Meron pang mga mas mahaba sa kanila, diba? So, actually, ito siya. So, what happens is that once the essential fatty acids are already provided, the body can already use them to build up the other longer fatty acid derivatives. Yan. So, makita nyo siya sa screen kung ano pa mga fatty acids ang build up once the essential fatty acids have been taken in. And our EPA and DHA are also encouraged or emphasized na dapat ini-intake pa rin sila through diet since their conversion from alpha-linolenic acid is poor. So we still recommend that they should be taken in through the diet. Okay, so konting review lang ulit before we go to the next part. So in terms of AMDR, what is the correct sequence of macronutrients in increasing amount? So ito yung percentages natin. Ano yung macronutrient na pinakamalaki yung percentage sa ating calories? At ano yung pinakakonti? So the answer is C. Pinakamalaki yung carbohydrates, fat, and then protein. How many grams of protein per kilogram of body weight is recommended for healthy adults? So the answer here is 0.8 grams per kilogram body weight. But disclaimer lang that this is for healthy adults. For athletes, we recommend 1.2 grams per kilogram body weight and sometimes more depending on their sport and the intensity of their trainings. Which of the following RDIs is not used as a recommended amount? And so our answer is the tolerable upper intake level. Okay, so now let's go to our nutritional disorders. So when we talk about nutritional disorders, we're actually talking about malnutrition. And malnutrition could come in the form of overnutrition, undernutrition, and micronutrient deficiency. So, hindi porket sinabing malnourished, that means payat or undernourished na agad. It could also mean overnourished or obese or micronutrient deficient. So, may pang forms yun, which will emphasize more in vitamins and minerals na lecture. But for now, let's focus on the 3 types of malnutrition. So, undernutrition is seen usually in malnourished children, in elderly, in patients with medical conditions with decreased appetite or altered digestion or absorption of nutrients, and patients with major trauma or infection. So, meron tayong dalawang extreme forms of undernutrition, and they're usually found for children. So, ito ay ang ating kwashiorkor and marasmus. So, in general, being malnourished depresses our immune system. And when our immune system is depressed or when we are immunocompromised, we are more prone to having secondary infections. And usually, ito yung nagiging cause of death when it comes to undernutrition. The complications that arise from being poorly nourished. So, makita ito sa picture, yung ating kwashiorkor and marasmus. But, now, let's look at them more deeply. So, kwashiorkor actually translates to the evil spirit that infects the first child when the second child is born. Ibig sabihin kasi nun, sometimes, lalo na sa mga areas na masyadong konti yung resources or very poverty-stricken, when the second child is born, all the attention and resources will be focused on that child. So, kapag kunwari, hindi masyadong malayo yung spacing between the first and second child, na dapat yung first child ay complementary feeding pa at may kasama pang breast milk. Pero meron na dumating na yung second child. So lahat ng resources ay mas mako-focus na sa second child. So mawawalan na bigla ng proper nutrition for the first child. So that's why it's the evil spirit that infects the first child kasi nangyayari siya usually sa first child kapag may bagong pinapanganak na bata. So that's why it's classified as an acute protein energy malnutrition because it happened quite suddenly compared to marasmus na i-discuss natin later. So kwashiorkor is often seen in children aged 1 to 3 years old when their diet is predominantly carbohydrates but lacks protein. So makikita natin symptoms dito ay stunted growth, skin lesions, depigmented hair, fatty liver, diarrhea, and decreased plasma albumin kasi konti nga yung ingestion niya ng protein. And this decrease in plasma albumin causes edema and swollen abdomen. Kaya kahit na kung makikita nyo, payat talaga yung bata, kapag tinimbang siya, hindi masyadong significant yung kanyang weight loss because of the edema. The key characteristics or symptoms of children with kwashiorkor are edema, swollen abdomen, and fatty liver. Okay, next, let's talk about marasmus. Marasmus are often found in areas where there is severe drought, famine, war, or scarcity of food. Unlike kwashiorkor, our marasmus is a chronic form of protein energy malnutrition. Sabihin, simula bata pa lang sila or minsan kahit na nasa sinapupunan pa lang sila ng nanay nila, nakakaranas na sila agad ng undernutrition because of how scarce the food resources are. So dahil doon, chronic siyang malnutrition. Or pwede siyang dahil na-wean na agad from breast milk agad yung infant and supplemented with watery cereals or over-diluted milk formula. When it comes to infant nutrition, we emphasize exclusive breastfeeding for the first 6 months. That means walang ibang pinapakain or pinapainom sa bata for the first 6 months aside from breast milk. Kahit tubig, we don't let the infant consume water during that time. It's just really breast milk. And after that, nag-start na mag-complement na iba't ibang pagkain para ma-introduce sa bata. Pero, meron pa rin kasamang breast milk. Ito yung form of malnutrition that could happen kapag tinanggal na agad sa breast milk yung bata. Tapos, ang pinalit na pagkain sa kanya, it's not even nutritious food items, kundi yung mga watery lang na mga lugaw or cereals or kunwari diluted na milk formula kasi kunwari nagtitipid. So, pinapagkasya sa mga magkakapatid. So, diluted yung milk formula. So, hindi na nakapag-provide ng significant amounts of nutrient for the child. So, symptoms of marasmus are arrested growth, kasi chronic na siya, so hindi nalalaki yung bata. Extreme muscle wasting, as in the picture, sobrang wala na talaga. Weakness, anemia, and severe weight loss. Wala siyang edema, unlike sa kwashiorkor, na may edema, kaya parang medyo moderate lang yung weight loss, but since sa marasmus wala siyang edema, so very severe yung kanyang weight loss. Okay, now let's talk about overnutrition or obesity. So overnutrition, as we all know, is associated with sedentary lifestyle and undesirable lipid profile. So most probably there are high levels of free fatty acid, cholesterol, and triglycerols. So overnutrition can also be caused by metabolic syndrome, hypothyroidism, Cushing's syndrome, and other medical conditions that affect our metabolism. So, ito yung mga hormonal changes na nakita natin when the patient is overnourished. Decreased perilipin level. So, perilipin is an adipocyte phosphoprotein that binds to triacylglycerols and regulates its accessibility to lipases. So kapag obese, mababa ang perilipin level, and as an effect, hindi na may utilize ang ating triacylglycerols. Next is leptin insensitivity of brain. Leptin, as we all know, is our satiety hormone. So, kung leptin insensitive na yung brain, hindi na tayo makaka-feel masyado ng satiety. And next is reduced adiponectin level. Adiponectin is the most abundant peptide secreted by adipocytes, whose reduction plays a central role in obesity-related diseases. So, because of this reduced adiponectin level, magkakaroon ng pwedeng insulin resistance or type 2 diabetes mellitus and other cardiovascular diseases. So, if the obesity happens before puberty, ang nangyayari ay both hyperplasia and hypertrophy. But if it happens after puberty, hypertrophy na lang yung nangyayari. And in the long run, obesity could lead to diabetes mellitus, hypertension, endometrial carcinoma, osteoarthritis, cirrhosis, gallstones, and other cardiovascular diseases. So now let's talk about our micronutrient deficiency. So, due to the lack of vitamins, minerals required by small amounts by the body for proper growth, development, and maintenance of physiologic functions. Ito yung mga micronutrient deficiency na prevalent in the Philippines. Iron deficiency anemia, especially for the women of reproductive age, and for pregnant women. Vitamin A deficiency for infants, and iodine deficiency disorder, lalo na sa mga areas na hindi enough, sa mga areas kung saan yung mga tao ay mas marami silang kumain ng vegetables when they live near the forest or kapag mag-asaka sila, usually they suffer from iodine deficiency kasi hindi na enough yung iodine na kuha nila through the diet. So actually, ito mga micronutrient deficiencies na to, translate sila into programs. Kaya, di ba, meron tayo yung golden rice, yung rice na enriched and fortified with vitamin A. And we promote the use of iodine salt para iodine salt para kahit pa paano maagapan itong mga micronutrient deficiencies na ito. Okay, so how do we assess malnutrition? So, number one, we can assess through dietary intake studies. The problem here is that it is not very reliable, pero madali lang siyang gawin. For individuals, we do a 3-day non-consecutive 24-hour food recall. Sabihin nun, kung kunwari, you try to make the patient recall whatever they ate in a 24-hour window for 3 days. Tapos yung 3 days na yun, they should be non-consecutive and they should compose of 2 weekdays and 1 weekend. So, for example, Monday, Wednesday, and then isang weekend, Saturday. Ganun siya. Tapos, nire-record din dito yung specific food items at kung gaano karaming food items yung kinain nila para ma-translate siya into nutrients. Makita kung gaano karaming nutrients na nakukonsume usually ng ating patient. Next is biochemical assays. They are best in determining subclinical nutritional deficiencies which can be treated before clinical deficiencies ensue. So, nasa gitna na siya na stage of malnutrition. Nasa subclinical na siya. Pero maganda siyang magamit sana bago pa makita or bago pa mag-manifest talaga clinically yung symptoms ng malnutrition. Next ay clinical signs and symptoms, but they are not desirable to rely on kasi ibig sabihin ay nag-manifest na yung malnutrition, and as much as possible, we still emphasize prevention more than just the treatment of the deficiency state. So, ano-ano ba yung stages ng ating malnutrition? So, meron tayong primary deficiency or secondary deficiency. Primary deficiency because of diet, lack in the nutrients in the diet, or secondary deficiency due to medications or other medical conditions. So, they they lead to dietary inadequacy. Kapag yung dietary inadequacy na-prolong pa siya, it could lead to a decrease in reserve tissue store kasi utilize ng katawan natin yung ating mga storage ng mga nutrients. And then kapag tumuloy-tuloy pa, it could be seen as a decrease in level of body fluids, decrease in functional level in tissues, tapos mag-decrease na yung activity ng nutrient-dependent enzymes, which would lead to functional changes, clinical symptoms, and then to anatomical changes. So, tignan natin kung ano-ano mga assessment tools yung pwede natin magamit for each stage. So, first, for dietary inadequacy, we use the dietary intake studies. When the reserve tissue store starts to decrease, biochemical na, and decrease of level in body fluids. They are all biochemical hanggang sa fifth, yung decrease in our nutrient-dependent enzyme. And sometimes, we can also see the functional change by observing the behavioral or the physiological aspect of the patient. And of course, for clinical symptoms, we rely on clinical signs and symptoms and as well as for anatomical signs.